This is Dr. Robert Bates at the Concussion Center of Fitchburg. Today we're going to discuss concussion screening and diagnosis. It is very important to do many things when a patient comes in for concussion. As we will run through this list, this is a hierarchy of importance. And what we want to end up with is a good diagnosis. So first we need to do a screening for indicators of emergency action. There are certain things that may not be a concussion, and we need to look for various things like blood pressure that is excessive, pulse rate that's lowering. We need to look at pupillary responses. We need to look at facial asymmetry and muscle tone and function so that we can rule out a CVA or type of CVA and not let it go too far before they get appropriate emergency care. After the emergency actions are taken care of and we are more sure that it is concussion, then we will begin to differentially diagnose the subtype of concussion by doing many different tests. And as we go through these, we will go down one road more so than another depending on what we find as we move along. So it's never an exact examination depending on what we find. So first we need a very comprehensive intake interview so that we know the mechanism of injury and the probability of certain types of trauma, especially to the cervical spine as well as the brain, since many of these symptoms will overlap. The examination will be decided as we go along and after we actually do a comprehensive intake interview. We need to decide what systems will be examined. The sequence of examination is based more on the levels of irritability, what we see for the patient's problems. A very good cervical musculoskeletal evaluation is necessary to see if there is impairment in the neck or in the muscles supporting the head. A vestibular ocular motor impairment evaluation should be performed, and very often we find small oculomotor dysfunction as well as vestibular problems, and many of these things need to be checked. And again, depending on what we find, we may do more and more in a particular subtype. We need to check for autonomic or external tolerance impairments to look for dysautonomia and other things that can be quite problematic in the long run, especially with the newer literature. We need to do a motor function impairment to make sure that there is no problem with mild weaknesses that are more central. We need to look for, of course, all of the signs of upper motor abnormality with spasticity and various rigidities and so forth. We then will look to classify the examination findings into various subtypes so that, of course, we can do further testing and come up with a very good action plan for treatment. The psychological and sociological factors must be looked at because everybody is different and everyone handles these things differently. Depending on what type of concussion you have or the various groups of subtypes involved, there can be a lot of cognitive and a lot of emotional factors going on that must be dealt with. Outcome measure selection is important. There are hundreds of tests that we can do to get a baseline, and of course we want to be able to know that we're doing the appropriate treatments and that we are getting results, and the only way we can really do that in any type of exact level to follow numerically is to have some type of metric with an outcome measure. We might do some type of balance outcome measure, various pain outcome measures, eye function measures. There are many things, and again, it will depend on what subtypes are involved. Communication and education to the patient is critical. Some people handle this well, other people do not. A large number of people are more depressed, they're more irritable, they don't sleep well, and they need to understand what is really going on so that they don't run away with these symptoms and become more psychologically ill. And then we need to look at various movement-related impairments so that these can be handled. The cervical musculoskeletal abnormalities must be addressed. We look for hypermobility, and we look for cervical repositioning and several types of tests to differentiate neck from vestibular abnormality. Excuse me. External tolerance and aerobic exercise is very important to look at because the newer literature suggests that aerobic activity within a metabolic limits is very important to increase metabolism, both mentally and physically is important in a concussion rehab program. The old thought of resting in the dark for 3 weeks is very much disproven, and if possible, within 24 to 48 hours, you want to start with some type of metabolically controlled activity, both psychological, cognitive, and physical as well. Again, we look at motor function, and we begin doing some rehabilitative exercise depending on what is involved. Again, many different potential abnormalities with motor function. So that is what the sequence should be, and of course that takes a long time to do that examination. When I do an exam, I block off 2 hours for a new patient to go through a very thorough history, certain types of testing, oculomotor function testing on a right eye's infrared eye tracking, computerized balance testing, pupillary light responses, possibly some rotational chair with video goggles, and we get a very good idea of the subtype. And then, of course, with more information, we can provide a much more specific treatment program and get better results. Again, always with outcome assessment. Have a great day.